appropriately with our healthcare system. This is medically avoidable mortality. This is where you actually get access to care, and it's not, you know, you could have avoided it, but you didn't. So we're not doing too badly there. When we do intervene, we're not actually killing people at a very high rate in our healthcare system. This is the breast cancer mortality rate in the OECD, 10th. This is one of the ones where we shine in colon rectum cancer. We have a lot of jokes around the Institute about why that is in Canada, but never mind. Shouldn't make jokes about people dying, I guess. Okay, so are we getting what we pay for in Canada? We have a high-cost system. We have worsening waiting times. We have poor performance on waiting times for elective medical care. We have poor results on access to doctors and technology, and mediocre performance on healthcare outcomes. Well, now, what is the problem? The problem is that the policies that we have in Canada. Now, I've got to go through this relatively quickly. I'm just going to mention them. When we look at user fees, for example, we don't have any user fees. They're outlawed. But in fact, 80% of the countries in the OECD do have co-payments, deductibles, and user fees in some of their activities. Canada is not one of them. Providers of public health care in the OECD. We have, in fact, total public ownership of our institutions. One of the consequences of that is that, for example, in the province of Ontario, the average age of a hospital is 40 years. The average age of a hospital in the United States is 9 years. If the public does it, then, you know, the capital allocation process is politicized. You don't get the kind of vibrancy and the kind of forward motion that you get when you have private capital involved. But you can see that within the OECD, about 60% of the case is mixed ownership, and in 40% it's public ownership and public management. So there is quite a lot of that in the OECD countries. Is there a private parallel healthcare system available? Not available in Canada and the Czech Republic, available everywhere else. And I'm going to come back to this because there is a very, very important clause in the proposal by the Blue Ribbon Commission, which would in effect put you in the same camp as Canada and the Czech Republic. And I'm not sure that this has gotten a lot of attention in your country, because if you weren't actually living with a system that has this provision, you wouldn't recognize it as being as sinister as it actually is. And I'm going to come back to it, but that once again is a way of keeping you on the edge of your seat. What is a sinister thing lurking in the Blue Ribbon Commission's report? Well, there is something lurking there. Well, is Canada unique? Well, it is in a way. Only 2 of the 28 countries surveyed have no comprehensive private provision of health care, Canada and the Czech Republic. Canada is the only country to have full and complete public management of hospital resources and no private parallel insurance system. Canada is the only country to effectively outlaw private parallel health care. There will soon be another country on this list if you go ahead to do what you do, and that will be the Bahamas. Now, if I had more time, I would spend a lot of detail on these universal health care programs that actually do work. Countries like Australia, Sweden, and Japan, for example, that have lower health care costs, better health care outcomes, user fees or co-payments, parallel private medical care, and supply parallel private medical treatment and supply publicly funded care. So in other words, these are countries that you might want to model yourself after. If you were going to come up with a socialized option, look at Australia, Sweden, and Japan and see how they're doing it. You might also want to look at Australia, where cost sharing accounts for 16% of total expenditure, where the benefit is 75% for professional hospital services and 85% for other professional services. There are no controls on physicians' fees. There is extra billing, for example, though physicians who accept 85% of the schedule can bill the government directly. Private health care insurance cover is available, and which is community rated with tax incentives. So you would want to look very carefully at Australia. Sweden. In Sweden, the counties county councils deliver care. There's co-payments for physician services, hospital care, outpatient care, elderly care, dental, and drugs. Fees vary by county, but are capped. Now, less than 2% of the resources devoted to healthcare come from patient fees, it is true, but you do have to pay to go and see a general practitioner. And so people in Sweden are involved in the decision about paying for some part of the care, and I'll come back to this in a few moments. There is no gatekeeping, however. People can go to a specialist without going first to a private, to a family doctor. And in some of the counties, like Stockholm County, which is in some ways the most important one, they've got a publicly traded, rather a privately owned, publicly trading on the stock exchange hospital called St. Gorans, which is now setting the diagnostically related group pricing for healthcare in Sweden, and the performance of that county is superb by comparison with the rest of the counties in the country. You also want to look at these countries because they all have features that we think should be in a well-designed healthcare system and are not in the Canadian system. You would, for example, have lower or similar healthcare costs, no waiting lists. They do have user fees or co-payments. They have parallel private medical treatment. This keeps coming up, that these countries that do better have parallel private care. And can you think of any reason why that might be the case? Can anybody think of a monopoly that works well? No. And why is it because the people who run the monopoly are lazy or stupid or whatever? No. It's because they don't have anybody who's looking over their shoulder. It isn't that, I always have to point this out, it isn't that private business people are smarter than the people who work in the government. It's that everybody who's in the private sector has got somebody else who's looking at their business. Somebody from the outside who's constantly looking at their business to see if they can do it better, if they can make more profit than the person who's in it now. It's competition that makes the private sector work better, and the lack of competition that makes the public sector not work. And we would all be the same. If we were all in the public sector, we would behave the same as the people who are in the public sector. Well, because that's the way we are. That's the way human beings are. That's why competition works better than not competition. So parallel private treatment is available in all these countries. Social insurance does finance the healthcare systems in all these in these countries, but private hospitals are competing to supply publicly funded care. Japan, well, I'm going to run out of time, but these are some other examples. Switzerland is, I think, a particularly good example. There's compulsory insurance. There's compulsory, everybody has to have insurance that's privately provided. There is risk redistribution within their system. They have deductibles that have to be paid by the patient. Direct patient payments accounted for 28% of total expenditures in Switzerland. But from the point of view of a healthcare system where you can get an instantaneous treatment for almost anything, you can't find a better system than the Swiss. It is, however, quite expensive. Not quite as expensive as Canada, but so you should look at the Swiss model. So then, how good is Canadian healthcare as a model for other people? Less than top performance in healthcare outcomes, ranks at the bottom in access to care, supply of technologies and supplies of physicians, and ranks at the very top in spending. And as I've noted, the problem is we have got the wrong policy. Now, I now want to show you something about the economics. I am, after all, an economist. I said before that the Blue Ribbon Commission's report is a Trojan horse for your future. And I don't make that charge lightly, because I'm sure these people, were well-meaning, that they did a lot of work, and they thought, I think that they just don't realize what they're proposing. And I want to show you now some economics of the Canadian healthcare system to drive this point home. I'm going to introduce you to two of my favorite characters, Trev and